I'm going to give a brief overview of our 28-year experience in complete repair and/or palliation for children with congenital heart disease and shunts, primarily post-tricuspid shunts, but we'll talk about that. We're going to discuss what we have discovered as the limits of operability. And let me just say that we are out in this field by ourselves. Not many people, as you will see, will operate on the type of children that we operate on. Dr. Emmer covered this quite well. There's no point in going into this significantly, but congenital heart patients are all in group 1. We don't deal with any of the other patients, quite frankly. Now, within group 1, you have all kind of different types lumped into this, of which congenital heart disease, as you can see, is one of the particular types of pulmonary hypertension that's in this. Now, imagine you have children with congenital heart disease, and yet you also have Africans, adults with schistosomiasis. This is a very diverse group of patients with pulmonary arterial hypertension. Now, this is the group that we're actually going to talk about, all children with left to right shunts. Now, we know that the flow will increase through the pulmonary vascular bed if there's a left to right shunt. Those individuals with non-restrictive post-tricuspid shunts will not only have the volume load, but they will also have a pressure load. And as a result of that, there is a shorter time period until they develop pulmonary vascular obstructive changes. And the damage to the endothelium can be quantified using either the Rabinovich, Marlene Rabinovich, or the Heath-Edwards pathologic classifications. Now, these are all the different types of defects that we've actually operated on, every one of these particular defects that you see here. The largest group that we have as a single group are ventricular septal defects, whether they are singular or multiple, as we've operated on quite a few of these children. Now, let's talk just a little bit about the Heath-Edwards changes. Dr. Umbrich showed this quite nicely. This is where we start to have a divergence of opinion, right here at the very first part of pathology. Yes, we agree. Reversible changes occur with type stage 1, 2, and 3. However, early in our experience, we also performed lung biopsies on some children, in addition to doing their operation for their VSD or truncus or whatever. We found that about 30% of our children on the biopsy specimen had stage 4 Heath-Edwards changes. So that should be irreversible. I'm going to show you some data that is going to try and explain this a little bit. Now, Marlene Rabinovich came along several years later and said, okay, we agree that there are significant changes that occur. And the Rabinovich categories of A1 and A2 are equal to Heath-Edwards classes 1 and 2. Her B1 and B2. So A1 and A2 are the top two. B1 and B2 are the middle two. And C1 and C2 are the bottom two. And as you can see, it would be almost impossible for you to change either 5 or 6, or C1 or C2 Rabinovich without some sort of pharmacologic intervention. And we're going to get to that in a moment. Now, there are routine, and I'm going to say Western, EU, US, recommendations for operability. And these have changed over the years. Initially, pulmonary hypertension by WHO criteria was greater than 4 Wood units, a mean pulmonary artery pressure of greater than 25. These things have all changed now. Now we're down to the fact that if you have a pulmonary vascular resistance of greater than 3 Wood units, you're considered to have pulmonary hypertension. And now the mean pulmonary arterial pressure is down to 20 millimeters of mercury. So those patients that have PVR less than 3, close the hole. Ligate ductus, no problem. Those patients from 3 to 5, well, you better be careful, they say, because greater than 5 Wood units, that does not decrease with vasoactive testing. You can consider shunt closure, VSD, PDA, AP window, etc., but you may have problems with those patients. And in those patients that their PVR is greater than 5 Wood units, you need to treat those children only at special centers that have a lot of experience with regards to the pharmacologic treatment of pulmonary hypertension, like Dr. Umbert's center probably. And then the last group, especially in the ASD group, if you've got a PVR that's greater than 5 Wood units, despite PAH vasoactive treatment with a negative vasoactive test, don't close the shunt. So I want you to keep that number in your mind for a moment or two. PVR of greater than 5 Wood units, poor reaction to vasoactive testing, on drugs, don't close the hole. We don't agree. Those are the European recommendations. These are the American recommendations, and they are almost identical. These recommendations came out 2 years ago as you can see, a scientific statement from the American Heart Association Council on Pediatric and Congenital Heart Disease. So one thing I want to point out on the text, I'd like for you to look at the last sentence. Consideration for fenestrated defect, closure of defects to reduce the QP, but still allow decompressive shunt, if needed, may be considered in high-risk populations. Those are all the patients I'm about to present to you, that very group. But we didn't fenestrate them, so to speak. I came to Kiev in 1994. Yeah, I've been coming to Ukraine for 30 years. It's hard to believe, isn't it? And I visited what would become the Amosov Cardiac Center. And I was assigned to assist a young, upcoming chief of a division of congenital heart surgery by the name of Vasily V. Lazarishinis. And I don't think there's anybody in the room that doesn't know who Vasily is. He approached me and said, Bill, we have a problem with children with VSDs and pulmonary hypertension. We operate on them and they die. Can you come up with some idea of how we can do this and have the children survive? So I went home after spending 2 weeks here. I looked at, I don't know how many kids with pulmonary hypertension. We didn't operate on any of them. And I started to look into the treatment of idiopathic pulmonary hypertension. Then I went further back into bench research. And, basically, I looked at everything I could. And at that time, for idiopathic pulmonary hypertension, those ultra severe cases with, quite frankly, dying, occasionally atrial septostomies would be performed on those patients so that they could actually, even though desaturated, get some blood to the left side of the heart. So we came up with the concept of, well, what if we were to close the VSD, have a hole fenestration in the patch, but on the left ventricular side, we put another patch, which is larger than the hole, and only fixated across the top 30%, so that when the RV pressure exceeds LV pressure, the flap valve will open. You will have, yes, desaturated blood, but it will flow into the left ventricle, and so you will not have the problem with not having adequate return to the left heart from pulmonary vasospastic conditions, and maybe they'll do okay. Okay, now, mind you, we're talking about children that were studied between 1996 and 1998. It's a very long time ago. There was no sildenafil. There was no iloprost. There were none of these things. So vasoactive testing was done only with 100% oxygen at that time. And you won't see anybody recommend that anymore. Look at the bottom. What's the PVR? It's an average of 11 wood units. Novick, are you crazy? You're not supposed to operate on these patients, okay? There were no deaths in this series. Because there were no deaths, we decided, well, let's expand this outside of Eastern Europe, because some of those kids were done in Belarus, some were done in Ukraine, most were done in Ukraine. And as many of you know, we traveled, to multiple different places in the world. And so as a result of this, we were able to operate on children throughout the world. And we ended up having a collection of over 90 children, with most of those being VSDs, but interrupted aortic arch, transposition, AV canals, double outlet right ventricles, corrected transpo, total anomalous with VSD. This is the collection of patients that we operated on over the course of about 8 years. And these are their Kaplan-Meier survival curves. Now, I've broken this down. The curve on the left, if you will, the very top line on the left is VSDs only. The middle line is everybody. So the bottom line is the complex cases. So that's the AV canals, that's the transpositions, et cetera. And as you can see, there's a distinctive survival difference between the VSD group and the complex group. And this is something that we sort of learned over time. But then we looked at it from the point of view of, okay, what happens if we look at it from the point of view of those patients with mild to severe pulmonary hypertension? And using a flap valve patch, we didn't find a difference in survival at 8 years, whether you were a VSD or whether you were a complex. Now, this is a short-term survival. This is only 8 years. Then we decided to look at it from the point of view of the pulmonary vascular resistance. So if you were greater than 10 wood units or less than 10 wood units, there was no difference in survival at 8 years. So, when sildenafil became available in Ukraine, we started using it on all the children that were going to undergo VSD closure. And this is what we found in that group of patients. We had 40 patients that had undergone the double patch VSD closure technique in the Amosov Institute. All those patients were followed immediately after operation at the 3-month time period, and then annually. We have annual follow-up on every one of these 40 patients, which I think is spectacular. 14 of these patients were placed on sildenafil when it became available. So the first 26 were done with no sildenafil. And we've broken this down for you so you can see what the difference is between the two groups. And as you can see, really, until you get down to postoperative pulmonary hypertensive crises or mechanical ventilation time, there's not a lot of difference. But sildenafil got these children off the ventilator quickly, and they were less likely to have postoperative pulmonary hypertensive crisis. Okay? But 25-year follow-up, almost. And we didn't find any difference in survival between the sildenafil group and the non-sildenafil group after the first 18 months. I said, okay, so what happens if you don't use the flap valve fenestrated VSD patch? So at the same time in Amosov, surgeons were allowed to decide whether they wanted their patient to undergo the flap valve surgery or whether they wanted to undergo traditional, we're just closing the hole. We ended up with a total of about 110 or 120 patients This is the survival probability from time of discharge, whether you use the double FAP or the traditional patch. You don't see a lot of difference there, do you? Those are the patients that were discharged alive. Those are not all the patients. The double flap valve patients had a mortality rate of 2.5%. One patient out of 40 died in the hospital. The traditional patch patients had a mortality rate of 10.1%. The double patch patients had an average age of 7.7 years. The traditional patch, 2.2 years. So you have younger patients that underwent traditional patch, and yet their mortality rate in hospital was higher. This curve, to me, is the most definitive curve about why you should not use a routine patch in a child with a VSD, severe pulmonary hypertension, and an elevated PVR after vasoactive testing. This is the predicted probability of in-hospital death dependent upon the following. What is your baseline pulmonary vascular resistance, systemic vascular resistance ratio, which is a very important determinant in the recommendations by both Europe and the US in terms of operability? And what's your saturation? And then how was your operation performed? Traditional patch or double patch? The curves are there for you to see for yourself. And what we have found is that the probability of in-hospital death is highest for those children that underwent traditional patch closure, that had saturations of 92% or less, and had a PVR, SVR, that at the end of the day, when it rose to above 0.3, which is the routine recommendation for both the US and Europe, had a higher probability of death. So, in closing, let me say, we believe VSDs can be closed in children with a PVR of greater than 6 Wood units safely if you use the double flap valve patch. We also believe that sildenafil pre-treatment provides an earlier extubation and shorter length of stay in the ICU. What does that mean? Well, that means the chances of you getting a nosocomial pneumonia are much less if you're extubated earlier and you stay less in the ICU. The use of the traditional patch in children with VSD and elevated PVR is a risk factor for in-hospital death. You just shouldn't do it. And the use of traditional patch in children with saturations less than 92% increases the likelihood of early death if the PVR-SVR ratio is greater than 0.3. Thank you very much.